Hey, Concord providers, this is Dr. John Jones, Chief Medical Officer for Concord Medical Group. I just want to provide a little education today on the subject of antibiotic stewardship. This is becoming more and more of an issue in our industry as we see more and more drug-resistant organisms emerging. It's an important part of our quality programs. Our hospitals are very focused on it, and we want to make sure we're using antibiotic appropriately. So we'll talk about antibiotic stewardship today. The problem as is presented is really a spectrum of infectious diseases that is rapidly evolving. Emerging infectious agents present with a constellation of challenges. Highly virulent pathogens expressing increased resistance to treatment with currently available antimicrobials will result in increased mortality, morbidity, and healthcare costs. It's estimated that 10 million people will die every year due to antimicrobial resistance by the year 2050. That seems like a long way away, but quite frankly, it's getting closer and closer all the time. Currently, it's estimated that 2.8 million antibiotic-resistant infections occur each year in the United States, and each year more than 35,000 people will die with one of those infections. As far as the organisms themselves, we'll touch on different classes. Those that are considered urgent threats at the moment are carbapenem-resistant Acinetobacter, Candida auris, C. difficile, carbapenem-resistant Enterobacter, and drug-resistant Neisseria gonorrhea. In the category of serious threats, we see drug-resistant Campylobacter, drug-resistant Candida, ESBL or extended spectrum beta-lactamase producing Enterobacter, vancomycin-resistant Enterococcus, multi-drug resistant Pseudomonas, drug-resistant non-typhoidal Salmonella, drug-resistant Salmonella typhi, drug-resistant Shigella, MRSA, drug-resistant Strep pneumo, and drug-resistant TB. All of those are in the category of serious threat. Other concerning threats include erythromycin-resistant Group A strep, clindamycin-resistant Group B strep, and then on the watch list we see Aspergillus, Mycoplasma, and Bordetella pertussis. All of these are growing concerns in terms of emerging antibacterial. All of these organisms are found on the watch list or various lists for emerging antimicrobial resistance, and all must be paid attention to. We need a proposed solution, and that solution is antibiotic stewardship. The definition of antibiotic stewardship is a coordinated effort to promote the appropriate use of antibiotics to improve patient outcomes and minimize drug-resistant organisms. Why do we need these programs? Through the indiscriminate use of anti-infective agents, including antibiotics, antifungals, antivirals, and antiparasitics, we as clinical providers, along with those who've gone before us, have brought about the creation of organisms that have developed resistance to many of our life-saving therapeutic medications. These resistant organisms are now in a place where they require different, more complex anti-infective agents and either have or will likely advance to a truly untreatable state. Patients who are or will be infected with those organisms are likely to have catastrophic outcomes. The goals of an antibiotic stewardship program, just to list three of them, are to reduce unnecessary antibiotic use, to improve patient outcomes by ensuring that antibiotics are used correctly, and to prevent the development of drug-resistant organisms. It's pretty straightforward. As far as who needs to be involved in the antibiotic stewardship programs, that includes medical providers, nurses, pharmacists, lab personnel, patients, families, and communities. You'll see that includes basically everyone. As far as how the programs need to work, there needs to be a development of an organized and coordinated effort to appropriately utilize anti-infective agents and to use them only in the right patients at the right dosage for the right duration. It will require education. It will require clinical decision support, monitoring, and feedback, as well as collaboration among the entire healthcare team. As far as the how of the program, education is at the forefront. All players must be educated on the rules of the game. Healthcare professionals receive a lot of education in their schools and training programs, but this education must be ongoing. This includes the appropriate use of testing, including rapid tests, as well as specimen cultures, and recognition of contaminants. Patients need to be educated also, specifically on the appropriate use of antimicrobials, including when they are necessary, how to take them correctly, and the risk of overuse and misuse. This includes completing the entire course of treatment as prescribed, and then community-wide education is important as well, so that our communities understand how these agents work and for what purpose we have them. In terms of clinical decision support, leadership engagement and support is vital to the success of any antibiotic stewardship initiative. Healthcare professionals need access to tools and resources to help make informed and timely decisions about prescribing antimicrobial agents. These might include prescribing guidelines, treatment algorithms, local and regional antibiograms, timely reporting of culture results, and other patient-specific data. With any good program, monitoring and feedback will be necessary. Prescribing patterns can be monitored and areas for improvement identified. Feedback can then be given to individual prescribers, along with supporting evidence and tools to help implement needed changes. Tracking and reporting of outcomes is imperative. To revisit who is necessary as part of these programs, we want to talk about the collaboration among that team as well. Those team members must work together to establish great protocols in order to get good results. Collaboration of the team is vital. Interdisciplinary teams working together to implement and evaluate these programs should include physicians, providers, nurses, pharmacists, infection control specialists, and administrators. Where are antibiotic stewardship programs needed? Well, quite frankly, everywhere. At least everywhere in our healthcare settings, including hospitals, clinics, and long-term care facilities. When do we need to get these things started? Well, right away. Good antibiotic stewardships need to be considered all the time and every time in the case of every patient. The time is now. Actually, the time was probably yesterday. We're behind the curve and organisms are outpacing us by the day. We need to get on top of this right away and get great antibiotic stewardship programs in place right away. The benefits of antibiotic stewardship programs are many. Just to name a few: reduced antimicrobial resistance, improved patient outcomes, lower healthcare costs, and reduced side effects and potential complications. Examples of antibiotic stewardship programs are many. We'll touch on a few of them now. Community-based programs, that includes patient education campaigns, pharmacist consultations, and access to educational materials on the subject of antimicrobial resistance. Hospital-based programs can be complex, but important aspects of those include the use of antibiotic guidelines, pre-authorization for certain antibiotics, and monitoring with feedback of antibiotic use. The use of an antibiotic timeout by physicians 48 hours after initiation of the antibiotic regimen is important. It's important to assess the ongoing need for the antibiotics, the choice and the route of the antibiotic, and dosage of the antimicrobial therapy. Pharmacy should be assigned to monitor appropriate dosages and adjust according to the peaks and troughs. On occasion, reasons should be required and pre-authorization before the use of vancomycin, ertapenem, and other broad-spectrum antimicrobials. It may even be wise to require specialist consultation for some antibiotics and approval before ordering. Adjustment and narrowing of spectrum once culture results are final and indicative of the presence. It is important also that we adjust and narrow the spectrum of our antibiotic coverage once culture results are final and indicative of the presence of underlying infectious disease. When we consider a good antibiotic stewardship program, we want to consider the 5 Ds. Those include the right drug, the right dose, the right drug route, the right duration, and timely de-escalation to pathogen-directed therapy. I just want to touch on a few specific considerations when it comes to specific infections. In the case of urinary tract infection, we should always ask when looking at a urinalysis, is it an infection or is it simply asymptomatic bacteriuria? Culture and colony counts are part of determining that. And we also need to consider the patient's symptomatology. We need to consider the location of the infection as well. Is it in the bladder and cystitis, or is the infection in the kidneys with pyelonephritis? There are different routes, dosages, and duration of treatment necessary for each of those, and we should consider the specific infection that's present. Moving on to upper respiratory infections, it's viral and antibiotics don't work. In terms of bronchitis, it's also viral and antibiotics don't work. We should not be prescribing the antibiotics in those cases. In the case of community-acquired pneumonia, it doesn't require broad-spectrum antibiotics. We should narrow our treatment options for the most likely pathogens. In considering skin and soft tissue infections, quite often draining the abscesses fixes the problem without any antibiotics at all. In the case of C. diff, we don't want to treat the patient who simply has a positive antigen. That patient also needs to have symptoms and be accompanied by a positive toxin test as well. And then moving on to sepsis, we know that when there's an unidentified source of infection that broad-spectrum antibiotics are appropriate. But we need to narrow that coverage once we understand which organism is involved and what the sensitivity of that organism is. When we know the source of infection, we should target that source with specific, more narrow antibiotic options. In summary, antibiotic stewardship is a critical component of healthcare quality improvement and public health efforts to control antibiotic resistance. By promoting the appropriate use of antimicrobial agents, we can improve patient outcomes and preserve the effectiveness of these life-saving medications. I appreciate your time and attention to our talk on antibiotic stewardship. I appreciate all you do in your work with Concord Medical Group. And again, I appreciate your attention today. Thank you. Have a great day.